Thank you very much for all of you attending, and thank you to our co-chairs of the meeting for wonderful meeting so far. Just really has been a great journey from the beginning. I'm really honored to have an opportunity to chair one of my favorite parts and sessions in the pediatric workshop is a debate. And I have two fantastic debaters here with me today. One debater is joining us online. Eleanor, I hope you hear us well. Just confirming. Okay. So I have two debaters today, Anna Turkova from Imperial College Health Trust, United Kingdom, and Dr. Eleanor Namusoke-Magongo from Ministry of Health in Uganda. And we have come up with a very interesting proposition for you to vote on. For those of you who participated in debate, you might be familiar with the rules. I will just refresh it for those of you participating first time. We are going to do a baseline vote on the proposition. Proposition will be reflected on the slide, and it is slightly changed from the text in the program, which is the same question, a little bit more refined. Then we will vote after that proposition. Please vote your view on that proposition. You will have three choices: yes, no, or uncertain. Then we will have our debaters present their points of view. We will have Anna Turkova pro debate on the proposition that you will be seeing, and you already see it on your screen. DTG transition, a switch to DTG must be accompanied by change in NRTI backbone in children with confirmed or suspected treatment failure. And after Anna, directly, Eleanor will present her con position on this. We will have few minutes to look at the feedback from the audience online and also hear some points here. And then each of the debaters will have the closing remarks, very short closing remarks, after which we will vote again. And that debater, the person who changes the most votes, is considered a winner in the debate. So just a little proposition here to start with. Now, I do want to make a disclaimer. The debaters don't always present exactly what they believe in. And I highly recommend that you grab them in the warm corner with a cup of coffee after all if you really want to know whether they agree with their proposition or not. So, but please do bear with us. And let us start today by welcoming again fantastic debaters. And Eleanor just expressing very deep regret that you are not here with us in person, thanking you for extra work and effort to make it work online, as well as virology education staff to make it feasible for Anna. Anna does have some privilege of being in person, but also not facing our opponent in person. So please help us to cruise through it well. So anyhow, let us go ahead and start voting. The instructions for voting will appear on your screen. You need to go to menti.com. Most of you have done it at the meetings. Here you see, take your cell phones, take your devices that have internet access. Please go to, or you can scan the QR code, or you can type the address there. And once you're on the Mentimeter website, you see there the submit button. Do not submit empty screen, and do not type your birth date. Type, enter the code that is on the screen, and send it in. Once you send it in, you will be taken directly to the screen that will show you the choices to vote yes, no, or uncertain about that proposition, and vote your conscience. And people online will be doing the same, and I'll have an opportunity to see the results here, as well as you will see the results on the screen. So we have a voting going on. We might need to extend it. Go back to the screen, please, Sam. We'll restart the voting. Don't enter your date of birth, marriage, or any other codes. Can we move to next screen? Is it good? No? Need more time? Okay. A slide is not going to change. Next slide is going to change. So if I hear no more objections, let us move to the next slide. By now, I hope everybody got the chance to know where you are. Sam, can we go? Thanks. So here we will start voting now. It's 1 minute for you to enter results. Don't read text, don't get distracted by WhatsApp messages. Vote. The code is on the top of the screen in case you forgot it. 77526681.
Can you repeat it? I think Angela. 52.
77526681. We have half minute. Grab your chance. Have your voice heard. Those who do not vote, you will stay in darkness. Nobody will know what you think. 15 seconds left. 10 seconds left. 3, 2, 1, 0. All right. So this is our starting base, as you can see on the screen, and this includes the online votes as well, so not only people in this room. So we have 33% who agree, disagree 40%, and undecided, fairly good pool of 26%. So Anna and Eleanor, you have work to do. All right, Anna, I give the podium to you.
Thank you very much, Natella, for setting the scene. Eleanor, I really wish you were here to help me to entertain all these people and keep them awake after heavy lunch. Dear ladies and gentlemen, those who are in the room and those who are joining us online, this House believes that a switch to dolutegravir must be accompanied by change in NRTI backbone in children with suspected or confirmed treatment failure. Please vote yes. First thing that you're doing while you're preparing to your debate is to explore about your opponent. Eleanor is not only the team lead for pediatrics and adolescents HIV care and treatment at Uganda's Ministry of Health. She is a fantastic singer, worshipper, and a speaker. She's probably the most persuasive person at this meeting, and she can make you believe. So keep your eyes open and keep your thinking hat on. But first and foremost, both houses believe that switch to dolutegravir should not be delayed as it improves treatment outcomes and may increase life expectancy. But what to do with NRTI backbone at switch in children who are experiencing treatment failure? So let's make a step back and think, who are these children we are debating about? You know these numbers. Of those who are on antiretroviral therapy, more than a quarter are not virologically suppressed. Of course, the numbers are very variable, and some cohorts of excellence show that less than 10 not suppressed before the switch to dolutegravir. But what NRTI's children are receiving? This technical report from December 2021 from WHO and UNAIDS shows that more than 75% are receiving abacavir at the moment. So we're actually talking about children who are failing on abacavir, whether to keep abacavir or to switch them to zidovudin or tenofovir when you transition them to dolutegravir. So what does our Bible say? The WHO 2021 guidelines say that for children with treatment failure on first line, we need to switch to a different NRTI backbone. And the rationale is to avoid functional dolutegravir monotherapy. And if you follow WHO guideline, you have to vote yes. And of course, the main principle of choose an ART regimen for second line that we followed for decades, and it's imprinted in our heads, do not change only one drug in patients with treatment failure. And why? This is HIV drug resistance report from the last year. And you can see the results of pediatric surveys on resistance from Uganda and Zambia. Here you can see NRTI mutations. You can see that 70% of children who experience treatment failure or virologically unsuppressed will have M184V mutation. Any level of Abacavir resistance is 70%, and high level of Abacavir resistance is around 20%. And this high level of resistance may be underestimated. Looking at the arrow, very large randomized controlled trial, children who were failing on Abacavir, the majority, more than 60%, had high level resistance to Abacavir at viral rebound above 1,000. From the study in Kenya, and this was 15 art clinics in Kenya, nearly half had a combination of L74V and M184V, which is both of them confer high level resistance to Abacavir. So really thinking about like around half, or maybe 60%, but this study in South Africa, which is in print, the publication, retrospective analysis of resistance data, showing that children failing on Abacavir regimen have got a predicted activity, 71%. If you start transition them on dolutegravir Abacavir 3TC, they will have dolutegravir as the only one active drug, as opposed to 7% who would have only one active drug if they were to receive dolutegravir zidovudin 3TC or dolutegravir tenofovir 3TC. And of course, we know this from previously performed trial that many of you participated, PENTA-5, CHAPAS-3, PENPACT. They all have previously demonstrated that using Abacavir first line followed by zidovudin or tenofovir in second line has resistance advantages. And of course, Odyssey randomized controlled trial, we did follow WHO guidelines. And in our second-line group, ODCB, nearly 400 children, nearly all patients switched their NRTIs at enrollment. We showed very high suppression rate. In second line, 89% were suppressed less than 400 copies per ml by 96 weeks. So dolutegravir plus 2 NRTIs work well for second line if NRTIs are changed. Let's see what adult trials can teach us. And these three trials, second line, Ernest, and Dunning. So Ernest and second line use at least one new NRTI as per WHO guidelines, and Dunning use at least one NRTI with preserved activity. And they also analyzed the regimens with WHO recommended NRTIs. All of them showed high level of suppression, from 81 to 87% of patients suppressed around 96-48 weeks. And note, a very small number of patients were on Abacavir 3TC for their second line. So there are no data from adult second line RCTs which support use of Abacavir 3TC for second line. So we all knew what we were doing before this trial revealed their results. So Nadia and Eleanor, I'm sure, will tell you more about the trial. It was a randomized controlled trial with factorial design with two randomization. And the second randomization was either to continue tenofovir 3TC or to switch to zidovudin 3TC in adults while they're switching to second line. And the results at 96 weeks showed that continuing tenofovir was superior to switching to zidovudin. What Eleanor is not going to tell you is that tenofovir superiority was driven by low suppression rates in patients with no M184 or K65R mutations. And actually, patients with M184 who switched to zidovudin had very similar suppression rates to those who continued on tenofovir. And actually, if you look at just in dolutegravir group, ignoring the darunavir group, zidovudin didn't perform too badly. Look at the suppression rate, 89 versus 92%. So my take-home points from pediatricians, from Nadia, of course, tenofovir is great for second line despite resistance. And if children can get tenofovir and eligible for tenofovir, please switch them to tenofovir. But zidovudin does perform okay with dolutegravir. That's what Nadia showed. And M184V makes HIV hypersensitive to zidovudin. So following the current guidelines and switching them children failing first line to dolutegravir zidovudin 3TC should work well. And Nadia did not study whether it's okay to stay on Abacavir. So what WHO HIV drug resistance report, they issued a caution. And you know, Eleanor was an esteemed steering group member. So she definitely participated in writing this. They say Nadia results cannot be readily extrapolated to abacavir, and caution is warranted when extrapolating results from studies conducted among adults. So please, listen to WHO guidelines and also listen to Eleanor. So let's have a look why we cannot extrapolate from tenofovir to abacavir. Just have a quick look about efficacy and resistance profile. Many of you will remember this adult trial, LA5202, which actually compared abacavir lamivudine versus tenofovir and tristabine in naive adults. And they had to stop the group of people with very high viral load because they didn't do very well on abacavir. They also found out that more major NRTI resistance was seen in patients on abacavir, and then we had 2 meta-analyses followed after that, which both showed that there is low efficacy of abacavir compared to tenofovir. Let's have a look at the resistance profile. We know that at least 70% of our patients have M184V mutations, and M184V does cause low-level resistance to abacavir, and you can ignore that, but it also increases susceptibility to tenofovir and zidovudine, and does slow emergence of resistance to tenofovir and zidovudine. So abacavir is not equal to tenofovir. What can we learn from real-world data in children? And please, if you haven't looked at this abstract, it's 49 and number 49 from HIV Pediatric cohort by Renee Wall and co-authors. They looked at the data on more than 7,000 children who were switched to dolutegravir-based ARD. 17% were virologically unsuppressed. And children who were virologically unsuppressed before switch, 32% remained unsuppressed at 12 months among those who continued the same NRTIs, and as opposed to 27% who switched NRTIs. Please note there were small numbers, no data on outcomes above 12 months, and no data on virological outcomes by NRTI backbone. You all watched yesterday very impressive data from BPI, a cohort presented by Jason. 12,000 children and adolescents received dolutegravir. Please note, viral suppression pre-dolutegravir rate was 95%. So when you switch to a more efficacious and better tolerated drug, you're not expecting anything lower, okay? Jason showed a beautiful graph, but I hope you all ignored the right part of that graph. Okay, because they're not very small numbers, they're not interpretable. Single drug substitution to dolutegravir, very exciting data. There were nearly 4,000 children. More than half of them were on abacavir. But please note, only 5% of them were unsuppressed. So actually, pediatricians in this BPI network did the right thing. You know, they all switched NRTI backbone in children who were unsuppressed, or nearly all. So among 210 children who were switched with single drug substitution to dolutegravir, 20% remained unsuppressed. And of those who switched from boosted PIs, 32% remained unsuppressed. Is it high or low? Difficult to say, because as there is no comparative data with children who change NRTIs. So why Jason driving very fast at AIDS 2022, where he will be presented the updated results on dolutegravir transition? But for me, the bottom line remains that children who remained unsuppressed after single drug substitution of the third agent to dolutegravir may be at risk of insta resistance. So we all get very excited of driving fast, but we need to be safe. So please don't forget and buckle your seatbelts. In summary, high-level resistance to abacavir is prevalent among children who are not suppressed. If you don't change NRTIs in children with treatment failure, you may leave them on ART regimen in which dolutegravir is the only active drug. And exposure to dolutegravir monotherapy does increase the risk for treatment failure and insta resistance. Remember, abacavir is not equal to tenofovir. If you have an option of switching to tenofovir, if you're lucky enough, have TAF or TDF, while switching to dolutegravir, please do so. If you don't have this option, follow WHO guidelines, switch to zidovudine, and support adherence. And please vote yes to say that a switch to dolutegravir must be accompanied by change in an NRTI backbone in children with suspected or confirmed treatment failure. Thank you.
Well, thank you, Anna, for this brilliant proposition support. We now want to hear no less brilliant proposition opposition. So the floor is to Eleanor. Eleanor, welcome. I do want to share, we believe Eleanor has limited capacity to share video, so we will start with presentation.
Thank you very much, Natella. And I would like to thank the conference organizers for this opportunity to speak about this very important topic. And special greetings to my opponent who has just been speaking. Please do not confuse the lady, the beautiful lady in that picture, to be the first lady of Canada. She is my opponent. And as you saw in the first voting exercise, she had some friends in here. But my goal by the end of this presentation is that you will all be weighing in towards do not change the NRTI backbone. Let's start with the WHO guidelines, as my opponent mentioned. When we look at the WHO guidelines, we learn that we are not required to have a viral load test prior to optimization to dolutegravir. And I would read an extract from the guidelines which says, viral load testing should not be considered a precondition to undertaking programmatic or individual transition to DTG-based regimens. When you look at this statement, it is a silent pointer to the confidence that WHO has in dolutegravir as the anchor drug, because what this means is that in situations where you cannot do a viral load test, you are going to start children on dolutegravir who are virologically unsuppressed with or without underlying resistance. So it is a silent pointer in the confidence that dolutegravir is an excellent drug that can work even with patients who are virologically failing with or without underlying resistance. Let's unpack this question. DTG transition, of course, the first part is obvious. DTG transition, if a child, when we talk about transitioning, we are talking about children who are stable, who don't need to change their NRTI backbone. But as explained, the focus of our debate today is among those who are failing, confirmed failure, or suspected failure. And we know that dolutegravir is recommended as second-line therapy in patients for whom non-DTG containing first regimens have failed. So you've already seen this slide from Anna. WHO recommends that we should change the NRTI backbone when children are failing from first line to second line. But the question is, do we really need to do this in the era of dolutegravir? And I would say no. You've already heard about the Nadia trial, and Anna has explained what the intentions of the study team was. They wanted to find out if dolutegravir is inferior to darunavir/ritonavir, and they also wanted to find out if recycling the NRTI backbone is better or not, as opposed to maintaining, to changing the NRTI backbone. And it was found in this study that dolutegravir in combination with NRTIs is effective in treating patients with HIV-1 infection, including those with extensive NRTI resistance, in whom no NRTI were predicted to have activity. So I want you to note the fact that even with no predicted activity, meaning that the slide that Anna was showing that showed that many children have resistance to NRT, to ABC, we are learning here that even with extensive NRTI resistance, patients will still do well on abacavir. And I know there was, the representation was not very good for children and adolescents in this study, but we know from the results that we can extrapolate this for children. So I want to say no to changing the NRTI backbone, because we know from this study that even with extensive resistance, patients can still do well as long as the anchor regimen, the anchor drug is dolutegravir. In addition, and what Anna didn't tell you, that when they maintained the TDF in second line for these clients, there were advantages beyond the viral load suppression. TDF in second line was found to be superior to switching to SZT in achieving viral load suppression. And also, by maintaining the NRTI backbone, there was reduced chance of viral rebound. The CD4 cell count was better, and possibly reduced risk of high dolutegravir resistance. So do we need to change the NRTI backbone? I would say no. Let's talk about the recent study, which other people have called the African Nadia. In this study, they looked at 1,201 participants, and they had two arms of study participants. In the first arm, they offered TLD, that is tenofovir, lamivudine, and dolutegravir. And in A2, they gave TAF, emitristabine, and dolutegravir. In arm B, they gave TLD, they gave TAFED, and we also see the standard of care maintained in arm B. So they were looking at those who had a viral load less than 1,000 copies and those who had a viral load greater than 1,000 copies. And what do we see in these results? So the outcome, the primary outcome of interest was a viral load less than 1,000 copies per mil. And we see that in arm A, we have good suppression rates in both the intention to treat analysis and the per protocol analysis. And when we move on to see the findings in arm B, you can clearly see on this slide that the standard of care, the zidovudine plus the LPVR did not perform well in terms of viral load suppression as compared to the other regimens where we had dolutegravir as the anchor drug. This slide is one, I'm very happy to present this slide because Anna is the PI for this particular paper. So I would like you to listen to Anna and the message she's telling us on this slide. She shared about Odyssey B, but she did not tell you about Odyssey A. In Odyssey A, where ART-naive patients were given dolutegravir, you can see from the slide that dolutegravir is protective against NRTI resistance. So if we add dolutegravir to our NRTI, abacavir in this case, because most of our children are now receiving abacavir, we have protection against NRTI resistance, as we can see from this slide. So I would like to plead with you to listen to Anna, as she tells us that dolutegravir is so good that it can even protect against NRTI resistance. Moving on to the next slide. This is programmatic data from the work that we are doing in Uganda. In Uganda, we started implementing HIV drug resistance testing about a year ago for children failing from first line to second line treatment. And we are currently in the process of writing a manuscript about this work. And I picked out this slide from that work to show you what is happening to our NRTI in terms of the clinically relevant mutations. So if you look in the red box, we see, so on the y-axis, we have the different drug classes, and on the x-axis, we have the individual drugs. So if you look at the NRTI mutations per these individual drugs, I would draw your attention to ABC, to AZT, and TDF. You can see that the proportions of children with clinically relevant NRTI mutations are highest among those on AZT. So you can see that the place that we want to go to for second-line ART is already showing us danger. Why would we move children from abacavir to AZT that is already telling us that do not come here? I'm more prone to give you NRTI mutations that are clinically relevant. So I would say maintain the NRTI backbone. Of course, the TDF here did better than the ABC and AZT, but we see better performance among children who are getting ABC. Let's also look critically at AZT, the drug that we want to run to in second-line treatment. It means taking your treatment twice a day. The patients that we are talking about do not know science. They want convenience. They want patient-centered care. So AZT would mean you are literally getting a patient, a child, an adolescent who is already stable on their once-day regimen to a twice-a-day regimen. This will lead us to adherence challenges that are already on the increase among adolescents, knowing very well that most of our children have been infected vertically, so they already have drug fatigue. In addition, we know that AZT has more side effects than ABC. We are talking at a patient level, here. We are going to struggle with challenges of anemia, neutropenia, to name a few of these side effects. We know that the side effects to abacavir are less, and the hypersensitivity reaction is even rare in patients taking ABC. Let's also talk about the challenges of monitoring the side effects to the drug. In resource-limited settings, it is sometimes challenging to even perform an HB test to determine the hemoglobin levels of patients. And sometimes, even when the test is done, because low cadre staff are the ones managing the ART clinics, it means that even the interpretation of these results will be a challenge. So do we want to give our children AZT in second line with all these challenges? I would say no. Vote for no change of the NRTI backbone. You've already seen this slide. Yes, the numbers are few, but we know and we can see that there's already an indication that with dolutegravir as the anchor drug, the viral load suppression is good. Let's go back to Anna and what she's telling us on this slide as the PI for this study. You can clearly see that on this slide, a high proportion of children, because they were looking at resuppression among those who initially have an unsuppressed viral load. And we see on this slide that a high proportion of children resuppress after virological rebound without ART switching. So this is further telling us, or Anna is telling us, that you don't have to bother to change the NRTI backbone, because with dolutegravir, even with the initial unsuppression, the patients are going to suppress. So do we need to change the NRTI backbone with all the challenges that come with AZT? I would say no. I would also, as I begin to wind up, I would like to tell you what we are doing in Uganda. We have the Uganda Pediatric ART cohort that has a nested HIV DR study where we are looking at children who are ART naive, those that are transitioning to DTG and failing on DTG. And we hope that about a year or two from now, will be able to contribute to this important debate or question. And as I begin to end, I would like to throw another spanner in the works. Do we need to continue performing HIV-DR from first to second line in the era of DTG as the anchor drug, or should we revert to empirical switching as guided by the ARV sequencing in the guidelines? Because by end of this year, most of our clients will be receiving DTG as their anchor drug. Therefore, once they are unsuppressed at the repeat viral load, it would be good to confirm if there's underlying resistance or not. So as I end with this slide, this debate to me is an issue of a mindset change, and we need it. In the past, when we talked about a switch, it meant that we should switch the NRTI backbone as well as the anchor backbone. But now we need more than before, a mindset change to understand that a switch now can mean only changing the NRTI backbone. So I beg you to move away from the analog era that has two antennas popping out of your TV. Why would you want a poor picture quality with two antennas popping out of your TV, taking AZT twice a day with all its side effects? And yet you can move to the digital era with a good picture quality, once a day regimen, NRTI protective, high genetic barrier to resistance, good viral load suppression, recycling your NRTI backbone. So I encourage you, vote for no change of the NRTI backbone. Take that leap of faith and let's give our clients a patient-centered ART regimen. Thank you very much.
I know you are presenting and busy, Eleanor. I wish you could see many sparkling eyes equally as to Anna's presentation, and smiles hidden by the mask. Some are open. But really, thank you very much for this very invigorating and very reciprocal representation to Anna in a way. We have just a couple of minutes for some really overarching comments from Bible writers, from anyone else who wants to comment. But otherwise, if anybody wants to speak up, you really have just a couple of minutes. Please do, if you want your opinion to be heard as widely as you hear. I have two hands. That's pretty much what we will take for now, and then let's see, because we need to vote. And I don't see anything. Sure.
Okay.
Yes, please.
I am not a Bible writer by any means, so please highly disregard my opinion. My question is, if we could do drug resistance testing, is this debate a non-debate? If we had that capacity, couldn't we just simply ascertain if the NRTI that the child was on previously can be maintained going forward? And I know colleagues in public health and program are going to say that's a lofty goal. We can't even get viral load testing done. How are we going to rise to the occasion of drug resistance testing? And I'll say I remain optimistic. I'm inspired by the work that Paul Farmer and others have done, who said, you know, in the time when people were saying we can't give ART to people across the globe, he said it's our ethical and moral obligation to offer this. I feel the same way when it comes to bringing equity in diagnostics and treatment monitoring. We can hope to rise to the same occasion.
Thank you so much. I will withhold giving the debaters chance to answer specific questions because they do have a couple of minutes for rebuttal points at the end, but I want to hear every opinion in the room. So we have 3 and then 2, and then we will go back to vote.
Thank you for the amazing presentations. This is a question to both speakers that can be after the rebuttal if you like. But I think these are excellent arguments, but I would argue that they're both based on expert opinion rather than evidence. And we don't really have any direct evidence to base our decisions in children for NRTI switching at second line. So how are we going to answer the question? Are we going to do a pediatric Nadia, or is there another way?
Great point. I think point of many discussions by many stakeholders in the room right now. And number 2, and then we'll go to vote.
So great thanks to both Eleanor and Anna. Anna, I have a question for you. Do you remember that Di Gibb wrote a paper in 2007 on Penta 5 comparing AZT-3TC versus 3TC abacavir and AZT abacavir, and AZT-3TC was less effective? I think it was published on 8. And why you are focusing on switching to AZT-3TC instead, for instance, of dolutegravir 3TC as a dual therapy, which has been shown to be very effective in adults?
Not in
No,
second line.
Well, I mean, but you know, this is not the second line, which is a transition, which is not the second line for failure. I think Eleanor made very clear this point.
Yes, please.
So I'll answer the first question first, and then the second, and then I don't know.
Quick.
All right, very quick. Alistair, thank you very much for the question. I do agree with you. There are no evidence to change our current guidelines, and therefore we need to follow what we follow. We need to change an NRTI backbone when we transition children with suspected or confirmed treatment failure to dolutegravir. And what are the way forward? I think we're driving too fast. There is no time for a NADIA trial. And all countries are doing the transition really fast. So, but we have wonderful data from a large cohorts. And I think we just need to exploit this data well and try to do comparative analysis. So pull the data together and look at the outcomes of children who were unsuppressed and changed to dolutegravir with and without change of NRTIs. I think this data, if you adjust for potential confounders, use some novel methodologies like propensity scores, then can give us good answers.
To be fair in the debate, Eleanor, I give you a chance to answer, and then we go on the round of last points. Eleanor, you on air?
Yes, I am. Thank you very much, Natila. I wanted to agree with Anna that we don't seem to have a lot of time to do the baby Nadia study, because the pool from which we would recruit the study participants is rapidly reducing as we all try to work hard towards moving children to dolutegravir. And we are beginning to see, I'll give an example, in Uganda, we have been stagnating in the viral load suppression rates at around in the 70s for years. We have now hit 86% viral. We are working hard to make sure that every child moves to dolutegravir, so we wouldn't have a pool of patients to enroll into the baby Nadia study. So with the improved viral load suppression with our children on MBC, we must keep them on their NRTI backbone. Thank you.
Thank you, Eleanor. And now the last closing remarks for our debaters to leave the long-lasting impression in you and to still try to influence your emotional memories. Please, Anna.
I told you Eleanor can be very persuasive. I was nearly converted. But when your leaders are fighting and you don't know who to believe to, hold on to the evidence, boy. We cannot extrapolate the results from Nadia to children, and I showed you why. Abacavir is not the same as tenofovir. No change in NRTIs may leave children on dolutegravir monotherapy with a risk to lose INSTI as a treatment option, and you see these kids in your cohorts. Real-world data show impressive viral suppression overall, but so far, small numbers for unsuppressed children who had no NRTI change at switch to dolutegravir, even smaller numbers who have outcomes at 2-3 years post-switch. No comparative data for those who changed and who didn't change their NRTI backbone. 20 to 30% who switch with no NRTI change remain unsuppressed and therefore at risk of losing INSTI as a class. We need more evidence before we can shift the paradigm. First, ethical principle don't do harm, and do not change one drug at a time when you change art in children experiencing treatment failure. We are not there yet to recommend dolutegravir single drug substitution.
Thank you, Anna. And now, Eleanor, your rebuttal.
From the Nadia and the Odyssey trial, most of the participants in the DTG arm who had virologic failure with DTG resistance were taking AZT. Do we want to go to AZT? I would say no. And for now, it makes sense to promote an approach that is person-centered, programmatically more feasible, and less likely to disrupt overall pediatric ART optimization plans with clear benefits to most children. Please listen to Anna when she tells us that NRTI is a very good drug in the Odyssey trial, and it is NRTI protective. We should focus on viral load monitoring after the switch, since this is easier to do than dealing with adherence challenges when you move down to a patient level. Many children will also be approaching the 30-kilogram mark, and thus will be able to take TDF. So do we want to keep switching these children around when we could maintain their ABC regimen, have a once-a-day drug with good adherence chances, and when they make 30 kilograms, we change them to TDF, where we now have evidence that we can recycle it in second line. So please vote for no change of the NRTI backbone. And I would like to acknowledge the following people for their support in preparing these slides. Thank you very much.
Well, now the time has come for you to say, where are you now after having heard these wonderful and brilliant arguments? We are going to launch the poll again. It's the same process, so I hope it goes faster this time. QR code, www.menti.com, and the enter code 77526681. 77526681. While you are voting, I want to, on behalf of both presenters, express great gratitude to all of you, because without your work, these presentations wouldn't be possible. The gratitude to the chairs, without them thinking and inviting debaters, this wouldn't be possible. And to many people who influenced these presentations directly by sharing thoughts and suggestions. Thank you, on behalf of presenters. Are we ready, Sam? Okay. Ready? Yes, looks like you voted already. All right, so Anna goes from 33% to 39. Eleanor goes from 40% to 57. And undecided shrinks from 26% to 4%. Eleanor, I wish you were here, because the cars to the car keys at the reception for winning prize. That's just a little hint to our sponsors on the global golden level. So for next year, we can make it more tangible, the win. And all of us can take a ride around Montreal in order. Eleanor, congratulations, and congratulations to both debaters. Absolutely fantastic debate.
Thank you. Thanks.
And it tells you that remotely still works, and being remote opponent with all the Anna's charm in the room, you still can win the debate.